Thank you very much for joining us, and it's great to be with you. I'm Peter Barlis, and I'm joined by my co-moderator, Dr. Jae-Hwan Lee. And it's great to be here to look at a series of cases focusing on complex percutaneous coronary intervention. So we've got an excellent array of speakers and panelists. I want to introduce our panelists. We've got Dr. Mohammad Pasciolly, Dr. Vincent Luk, and Dr. Jun Pu, who we expect will develop some very interesting comments and questions and make it as interactive as possible, of course, over the waves of the internet. So we've got a great combination of speakers focusing on all aspects of coronary, structural, imaging, and peripheral work. And I really think it will be a very, very enjoyable session and hopefully educational for you all. So I'll pass on to Dr. Lee to introduce our first speaker and to start the presentation.
Yes, good afternoon, ladies and gentlemen. Our topic is a complex PCI, but 6 cases are all around of the body: coronary, peripheral, carotid, and structural heart disease. So I'll introduce the first case by Chak from Prince of Wales Hospital, Hong Kong, China. She'll present a chest rig, a case of valve in ring.
So this is Kent from Prince of Wales Hospital. So good morning. So today I'm going to share with you a case of valve in wing with mitral paravalvular leak closure. So I have no disclosure. So the patient CT is a 75-year-old lady. So she has history of mitral wing annuloplasty using a 30mm saddle wing in year 2011 for mitral regurgitation. She also has breast cancer with radiation and chemotherapy done, which is complicated with chemo-induced non-ischemic cardiomyopathy with an AICD implanted. She has atrial fibrillation and also has prior atrial fibrillation ablation done. Notably, she is a Jehovah's Witness. So she come to us with 6 months of exceptional shortness of breath. And this is her transesophageal echocardiogram. You can see that there is a wing dehiscence at the posterior aspect of the wing. And there is also severe tattering of the posterior mitral leaflets, leading to severe mitral regurgitation. And the jet of the mitral regurgitation was divided into a central one and also the one that is going through the wing dehiscence. So there were 3 interventional options that we can think of for this patient. The simplest option for this patient would be to redo open heart repair. Unfortunately, she is not a surgical candidate because she is a Jehovah's Witness and she refused any kind of blood product. And the fact is, her baseline hemoglobin was only around 8. Second option would be to perform transcatheter edge-to-edge repair using mitral clip or Pasciolly device. But technically, her anatomy is quite difficult because there is a mitral wing annuloplasty in situ, and there is severe posterior leaflet tattering. There is also imaging difficulty because the wing annuloplasty was shattering the posterior leaflet when we want to perform interventional edge-to-edge repair. So the last option would be to perform transcatheter mitral valve replacement, a valve in wing procedure, and at the same procedure to perform wing dehiscence repair using plug device. This is the option that we chose at the end for this patient. So let's review the saddle wedge wing. This is a 30mm widget saddle wing, and according to valve in valve app, so we can choose a 26 Sapien 3 valve inside a 30mm saddle wing, and the conformation is actually pretty good. But for all widget wing, there is risk of new dehiscence after you post-dilate or aggressively inflate the valve when we're doing the implantation. And the pre-op CT was shown here. So the dimension of the wing is matched with the valve in valve app, which is suitable for a 26 Sapien 3 valve. The good thing for this patient is that the left ventricle is quite dilated, despite the fact that the anterior mitral leaflet is long and is not resected. there is very low risk of having left ventricular outflow tract obstruction because of the LV dilatation. So for the actual procedure, what we do first is we try to cross the wing dehiscence from the get-go so that we don't have to cross after the transcatheter valve is implanted, which we think at a time is easier. So after crossing the wing dehiscence, we actually exchanged to a 6 French shuttle sheath, planning for subsequent plug device repair. And then we cross the mitral annuloplasty vein using a balloon tip float catheter. There is also a pigtail catheter inserted retrograde from the aorta for monitoring the outflow tract gradient. So after exchange all these equipment to stiff wire, we then proceed to transcatheter mitral valve replacement using a transeptal approach. So we perform septostomy using a 14 by 40 millimeter Armada balloon, and the 26 millimeter Sapien 3 valve was implanted. So the implantation looks a bit atrial, but to us we think is quite good. So then we commonly perform 2-stage inflation. So this, you can see at the second stage of the inflation, we didn't stop the rapid pacing, and then we add extra 2 cc. So after the TMVR was performed, you can see, as expected, the wing dehiscence leak still persists. So then we proceed to wing dehiscence repair. Unfortunately, when we're exchanging the catheters out, because we want to put 2 catheters out because defect is quite big, we probably, one of the wire crossed one of the cells of the newly implanted transcatheter heart valve. So we were not able to realize that at that time. So after implanting a 10 millimeter VSD occluder and also an ADO occluder, as shown here, we then find out that the posterior wing dehiscence leak were mostly gone, but then one of the occluder protrude into the transcatheter heart valve and impinge the new leaflet, causing central mitral regurgitation. So what we do is we try to settle that problem using a new transcatheter heart valve, same 26 Sapien 3 valve, and the central leak were gone because the new leaflet were implanted. But we still have to settle. What we found at that time is that we found that, let me show you back the picture. We actually found that there is a new leak that was detected, which is not found at the very beginning. We found that there is actually a new wing dehiscence because of the aggressive post-dilatation at the trigone region. So at that time, we decided to also to repair that leak. So we crossed the leak using a Gillis catheter inside an empty catheter and also a stiff angle glide wire. And then we were able to deliver a 4 French top view low profile and implant a 4x4 ADO2 device. And this is the final result from the transesophageal echocardiogram after plug, a valve in wing and valve in wing procedure. And the result is actually very good. There is minimal residual paravalvular leak and no central mitral regurgitation. But from this case, there were 2 discussion points. First is, in this kind of case scenario, what would be the more optimal approach? Do we do MER, transcatheter edge-to-edge repair, or TMVR with wing dehiscence repair as in our case? And if we decide to do wing dehiscence repair together with TMVR, what would be the accurate, what would be the preferred sequence of intervention? Should we do TMVR first, or do wing dehiscence repair first, or get access first and do TMVR as what we did in our case? So to conclude, I would like to share this case and then to illustrate that TMVR with PVL closure is visible to tackle recurrent mitral regurgitation post mitral wing annuloplasty with wing dehiscence. And obtaining access across the wing dehiscence before TMVR valve implantation is important because that can actually try to avoid wiring across newly implanted transcatheter valve stents drop. And unfortunately, our case, because the exchange wire process has some problem, so we unfortunately crossed one of the stent strap, which we have to check from time to time when we're doing wire exchange. And valve in vein TMER could result in vein dehiscence, and commonly was located at the trigone region, which we have to be aware of that and be ready to chase the leak in all valve in vein TMER cases. Thank you very much.
I'll introduce the second case. Second case we will present with Kahe Ho. The topic is the death combo of triple CTO and very low ejection fraction, 15%. Dr. Ho, please.
So we have a case of triple CTO with a very poor LVEF of 15%. Actually, was it compatible with life? So we'll share a story of our patient. So this is a 70-year-old gentleman with good past health. He was admitted for acute coronary syndrome, but he presented with chest pain for 2 days already. He also complicated with acute pulmonary edema requiring BiPAP support. The chest X-ray is congested. ECG shows there is a subtle ST elevation over the anterior lead. So we did a coronary angiogram for the patient. So you can see that actually the LAD was totally occluded with no retrograde. Circumflex was also totally occluded at distal with some retrograde from the LAD. And RC is also totally occluded with very anti-grade flow. So what makes it even worse with this coronary angiogram is that the LVEF is very poor. The anterior is not moving well, around the LVEF around 20% by echocardiogram. So we proceed to the MRI heart to guide our revascularization plan. It shows there's 9 segments of transmural LAGAC, which that's actually not recover even with revascularization. We consult our cardiosurgical team. The patient is not benefit from CABG, and therefore after team discussion, we plan for impeller-assisted PCI. So we implant the impeller. So we decide to tackle the left system first. So this is the LAD. Now some retrograde has been formed after a few days. And because it's likely to infarct the vessel causing this acute event, the plug is a bit soft, so we can successfully wire it with workhorse wire with carousel support. And we predilate it. But you can see that actually is a diffuse disease. So we did IFIS and show actually diffuse disease over the distal vessel with no landing zone. And we decided to land a mid-LAD instead to stand all the way to the distal, which is very small. So this is the final result of the LAD. It's quite good, but with a diffuse distal disease that we have none intervene on. So then we proceed to PCI to circumflex. Workhorse wire is not able to wire through the third total occlusion, but we successfully wire with XTA. So after wiring and with some balloon dilatation, we can see the vessel is like this. And we stand from the proximal and to distal. And this is the final result of our left circumflex. It's quite good. So for our patients with triple CTO, we have 2 CTO done already and only 1 more to go. However, this is actually the most difficult one. So our first obstacle, because we're doing PCI for the right femoral, but we're also trying, we are trying to do a contralateral injection for another femoral artery through the impeller sheath, but as you can see, sorry about this, the wiring is actually, even with a terumo wire, is very difficult. And even we wire it, we're unable to insert the sheath over it. So we cannot perform any contralateral injection. The wiring is extremely difficult. As you can see from the angiogram, there is a multiple CTO segment. We try with different wires. We try the XTA, HTR, and also we try the Gaia 2 and also Gaia 3. But although from the RVO field that you can see that maybe we are on the right track, but actually on the lateral field, we are in the subintimal space. Then we proceed to the parallel wire technique with a dual lumen microcatheter, but still we are not in the right place, as seen in the lateral angiogram. So we have tried, we used more than 1 hour to try to wire the RCA CTO, but still fail. But at the end, when we want to give up, miracle has happened, and that we are successfully wired the with the RCA CTO with XTA. But then even with a successfully wiring, we are unable to pass through the balloon over the mid-RCA segment. We have used a guiding extension with Guide Plus. We try to use very small balloon with a 1.0 and 1.5 balloon, but we're still unable to pass through it. And even with a 0.85, a very, very small balloon cannot negotiate through the mid-RCA. So why is life so hard, wiring so difficult with triple CTO, and we are unable to pass through the balloon? But sometimes it just takes time. So we able to pass through the balloon after very, very repeated sequential dilatation with small balloon, with small compliant and also non-compliant balloon. And later on, we actually successfully wire and pass through the balloon to the distal RCA, as shown here. And we are able to stand it from proximal to distal. So this is the final result of RCA, but actually the PD is also totally occluded. But I think it's good enough to have a proximal to have an RCA intervention. So the patient went off the impeller on the day of PCI, and actually the echocardiogram showed there's an improvement in LVEF, and he was put on Entresto and Concorde, and he was put on cardiac rehabilitation, and he was discharged 1 month after the PCI. So after a few months, the patient actually now in New Heart Association Class 1, functional Class 1, and able to walk unaided for 1 to 2 hours every day. So in the past, high-risk coronary anatomy impaired LVEF means the patient may be dying, is death. But now we have a lot of mechanical circulatory support, including impeller, ECMO, and a lot of new technique that we can use, that we are seeing some light in this kind of patients. And also even for these patients that we can see a lot of non-fibrable segment on MRI. But actually after revascularization, we can see the patient actually have echo and also clinical improvement by revascularization. So sometimes we can consider revascularization even there is some non-fibrable segment on MRI. So this is the end of our presentation. I present a case of triple total occlusion in a patient with acute coronary syndrome, acute pulmonary edema with a very, very poor LVEF. And we successfully tackle the triple CTO with some difficulty in between, but actually at the end, we are able to save the patients. That's the end of my presentation, and thank you very much. And welcome for any discussion on this case.
Oh, very nice presentation. You have very brave heart for all the procedure in the same situation. So, is there any question from the panelists or anyone?
Dr. Ho, that was a phenomenal case. I'm amazed that you persevered so much. Can I just ask the technical elements? I mean, how much contrast did you use in this case?
We actually used around 100, I think 150. 150, yes. We didn't use a lot of contrast, but we tried to use a little bit because his actually renal function is a bit impaired. So we try to avoid the contrast and also as far as possible. But during the RCA CTO, we need to inject a lot of contrast. But at the end, he doesn't need any renal support for this.
Well done, well done. Dr. Pasciolly, did you have a question?
Good. Thank you, Dr. Peter. I think it is the Mr. Jae-Hwan who is good presentation, but I will to comment about this is ejection fraction with 14% change to 25% in my is with the advanced heart failure therapy. I want to ask about Jae-Hwan. Do you have the his research about the long-term outcome PCI low ejection fraction with the only optimal medical treatment? Because this is the MRI is not fiber. What is your opinion?
I think
conservative with the optimal medical treatment with the heart failure. Only you go to PCI complex.
Yes, we also have this kind of questions all the time because we see a lot of non-viable cases that's on MRI, but somehow with our experience, we found that even with non-viable segment on MRI, we do see patients with improvement, even though it's non-viable on MRI. This is just our own center experience, but I think for this patient, we can see a lot of improvement. I haven't got the echocardiogram shown after the PCI, but actually sometimes has improved a lot, and I think even a bit of improvement over the LVEF over some of the Fileman segment has already improved, sometimes a lot. So he has been backbound for 1 month during his admission for us, but now he could walk and later. So I think some improvement over the LVEF is also good, but actually for this kind of cases with ischemic cardiomyopathy, I think even with a very good medical treatment, like with ARNI, beta blocker, which you can see a lot of patients still suffering from a heart failure, even with just medical therapy. So I think revascularization is the key in this case and does help a lot.
Would you consider this patient still suitable for an implantable defibrillator, even after you revascularize the patient?
Yeah, we will see. We will follow up him regularly now. Currently, he is in a class 1 functional class, so we will have a follow-up echocardiogram for him after a maximization of his heart failure therapy. If it's still impaired, for example, 30 or 35, then I think he is good for a primary prevention of for his ischemic cardiomyopathy.
Well done, Dr. Ho. Great case and well presented. Thank you very much.
I have one more question,
Yes.
Dr. Ho. If I were you, I will split the procedure. After radiant circle intervention, maybe RCA CT intervention will be postponed for the safety, because this patient is presented acute pulmonary edema. So I think splitting is not another good option. The second question is you puncture only single artery because the contralateral femoral artery is occupied with the impeller device. So at the time, I can puncture additional puncture ipsilateral single site for the right femoral artery, 2 punctures, or you can use a transradial approach for the, because 2 simultaneous injection may increase your successability and decrease complication. So you can consider
yes.
Kind of, excellent feedback, Dr. Excellent feedback. Thank you very much.
Thank you.
All right. I'll get you to introduce our next speaker, Dr. Lee.
Okay. The third speaker is Dr. Hsinyu Tseng from National Taiwan University Hospital, Taiwan. The topic is efficacy of serial balloon pulmonary angioplasty in treating an octogenarian with severe CTEPH and right heart failure. Dr. Tseng, please.
And I'm Dr. Hsinyu Tseng from National Taiwan University, Taipei, and today I'm really happy to share a case with a severe CTEPH with you. So I know nothing to discuss here. And this is an 80-year-old female presented with progressive dyspnea for years. And she had a history of pulmonary embolism and later developed chronic thromboembolic pulmonary hypertension, CTEPH. Luckily, she had been enrolled in the REAL-C-Blood global trial, the CHEST-1 study, which was the only medication approved by FDA. But 5 years after the medical treatment, her symptom recurred, and she was admitted for workup. Her mean pulmonary artery pressure was 55 at diagnosis and now increased to 60. And echocardiography was done that showed right heart dilatation and the TR pressure gradient increased to 128. VQ scan and dual energy CT was done, and there's a bilateral perfusion defect with right lower lung the most severe. And we also arranged a first pass nuclear study to assess the RV function, and there's a borderline decreased RVEF. To comprehensively assess a CTEPH patient, ESC have proposed a risk assessment tool using clinical laboratory hemodynamic and image study, and to classify the patient into low, intermediate, and high. And we can see a lot of parameters of this patient are classified as high risk, meaning that her controlled CTEPH is not very good. So what can we do for her? Since she's an inoperable patient and medication has already been given, a BPA should be considered. And therefore, she received her first BPA in June 2016. Let's look at the non-selective angiography. there's a left lower lung vessel narrowing and decrease of perfusion. And compared with left lung, there's a more severe vessel narrowing and markedly decreased perfusion, and even a slower pulmonary vein return. A lot of diseased vessels were noted and which should be treated first. To answer this question, we should consider the safety and efficacy. For safety issue, slit and web-like stenosis should be treated first, and the CTO-like lesion should be postponed. And for efficacy, her right lower lung has the most severe perfusion defect, so we decide to treat the right A9 and A10 first. We use a 65 centimeter 7 French long sheath and JR4 guiding catheter successfully engaged the right A9 and A10 and confirmed there's a slit and web-like stenosis. And we start our procedure at A10. We use a C-on wire to wire through the lesion and use a 3 and then 4 millimeter balloon for proximal lesion dilatation. However, we face some difficulty when wiring to distal A10. And we then apply the dual lumen catheter Crusade and hydrophilic wire filter FC. Under the support of Crusade and filter FC, we can finally go through the lesion. And we use a 1.5 millimeter balloon for angioplasty. And we now move to the A9. Since we have the experience on A10, we know that A9 will not be easily as we expected, so we use UB3 as our first wire. But UB3 still got stuck in the middle of the A9. And again, we apply Crusade and UB3, and then even under the Crusade support, UB3 still very struggled to pass the lesion and could finally reach the distal A9. And then we use a 3 millimeter balloon for angioplasty. So we have performed a selective angiography to assess the treatment effect. The stenosis has improved, and there's a markedly increased perfusion, and the venous return got faster. Total procedure time is less than 2 hours. Since there are a lot of diseased vessels, should we treat it now? Well, we should remember there's a unique complication called reperfusion lung edema. And what predicts reperfusion lung edema? Some experts have proposed a score named PEPC. It's the change of a pulmonary flow grade score multiplied by the PVR in this unit. And the patient's PEPC score now is 50. According to previous study, lung edema rarely develop PEPC score is less than 35, but if it's higher than 35, we should be very careful about it. The patient still have pulmonary edema, but she did not receive intubation, and the lung edema improved in 2 days. In the next coming 3 years, she received total 8 times of procedure. And after 8 times of serial BPA, her mean pulmonary arterial pressure decreased from 60 to 30, and PVR decreased from 16 to 3. And there's a clinical and laboratory improvement. Echocardiography also shows there's an improvement of right heart dilatation. TIPG decreased from 128 to 49. And initially, there's a lot of perfusion defect in bilateral lung, especially the right lower lung. And after the procedure, the size of the perfusion defect shrinkage. And the resting RVEF increased from 47 to 54. The stress RVEF increased from 44 to 64. More important, initially less exercise-induced RV dysfunction, but now her exercise capacity improved. To comprehensively assess the patient, use the ESC tool. Under medical treatment, a lot of parameters are classified as high risk, but after BPA, most parameters are classified to low risk. So my conclusion is BPA is an effective treatment for an inoperable CTEPH patient. And this lesion seems can be easily managed, but difficult wiring are frequently encountered during the procedure. By applying the long sheath dual lumen catheter to increase support and careful manipulation of a hydrophilic wire can facilitate the procedure. And reperfusion lung edema is a unique complication. We should be very careful when managing the patient with a high PEPC score and a high PVR. Okay, thank you. And this is my discussion point.
Yes, excellent presentation. You did 9 procedures for both pulmonary arteries, maybe. And what is the criteria for endpoint of each session?
Well, yeah. First, I have to say that each complete procedure should be separated. And the endpoint of each procedure is based on the PEPC score, or some expert has used a distal pressure wire as an endpoint. Let me show you the slide. Some scholar had used the pressure wire because when the distal pressure increased to more than 35, there's a higher risk of reperfusion lung edema. So these 2 parameters can serve as the endpoint of each procedure.
Dr. Reza, please, yeah.
I want to ask about how long did you, after procedure, give anticoagulant for long
Well,
term or?
Because CTEPH, okay. Because CTEPH is a chronic thromboembolism, so the patient should be put on anticoagulant for lifelong. And this patient, she also has a history of atrial fibrillation, and so she was put on a DOAC.
Okay, if the patient now have atrial fibrillation, only chronic thromboembolic pulmonary hypertension because of chronic venous insuffisiency.
I think according lifelong, because
still lifelong. Okay.
Still lifelong, yeah.
Have you had, Dr. Tseng, any follow-up on these patients clinically, but also, you know, how much improvement do they get in their pulmonary pressures over time? And how long have you followed up some of these patients for?
Well, we have followed the patient non-invasively, like a perfusion scan, 6-minute work test, or no X-ray functional class, and echocardiography for right heart function, and the first pass exam for right heart function. And as for the invasive exam, we generally do not routine follow up the patient because it still carries a risk. But if there's a change in clinical symptom, we will have her admitted immediately for right heart catheterization.
Okay. I think the edema complication is a very important one to highlight. I mean, as I said, I don't do any of these pulmonary interventions, but I think it's important to recognize that complication and try to plan and prepare for it, because it can be pretty significant and you know, on the patient.
Yes.
Thank you very much. I think that's an excellent presentation. As it raises questions about potential future results and long-term outcomes and potential applications of drug-coated balloons in these patients, whether that might have a role in some of these to provide long-standing results. But great work and very well presented. It's great to be able to introduce our next speaker, Dr. Jae-Hwan from the National Heart Institute in Malaysia. And here, Dr. Win is presenting on PCI and spontaneous coronary artery dissection. It's really a very important topic, and we're presenting some information here about the use of IVUS guidance and further evaluation of SCAD. So, Dr. Win, please start.
So I'm Win from the National Heart Institute of Malaysia. So my topic is like the patient came with the spontaneous coronary artery dissections, and we did the PCI and the IVUS guided. So basically, I have no special potential conflicts or contracts to disclose. Basically, I would like to share this history that this is a 58-year-old gentleman who is no medical illness before. However, he presented to a district hospital with a recurrent chest pain for a few times in 1 year, and then 2 times was for the unstable angina. So one of the risk factors is he was a chronic smoker, but there is no history of drug abuse. So we counsel him for proceeding for the coronary angiograms. So at the same investigation result shows that ECG show there is a T inversion in V1 and V2 only. And then the other places looks quite normal with a normal X6 and sinus rhythm. Blood investigation were normal, renal function was normal, liver function was normal, cholesterol also like 3.9 only, and LDL was 1.9, and cardiac enzyme were normal on admission to our site. So angiogram shows the circumflex, quite smooth, normal. So LAD also quite good, no atherosclerotic lesions, and then quite smooth artery. So however, the RCA showed there is a lesions. Okay, this lesion looks like very simple lesion, type A lesion. Okay, we can finish with short period, with just wire and put the balloon and what stent. That's it. So we thought quite simple. Then we proceed. And so we did a pre-dilation with the 2050. After the pre-dilation, there was no flow. You can see that, wow, that time my heart would sink. What happened? Did I went into the false lumen, or did I go into the make the dissection, or something happened? So I take a shot. So see that looks like the wire is in the false lumen. So and then I pull back the wire and pull back and do the very, very meticulously, and then to the distal RCA. Then at that time, we pre-dilate again. So at that time, the flow was back to the distal RCA. However, we can see that there's no more flow to the RPTA. Oh, then we think, okay, there is something happened. Probably we can see that there is a dissection which might extend to the distal RCN, causing a no flow phenomenon. So we give at that time we give the antigen, we give the adenosine. However, the flow was not improved. Then we decided, okay, probably my wire induced a dissection, or probably spontaneous coronary artery dissections with the extension of the hematoma. So then we decided to put the drug-eluting stents into that part, and then that particular part to seal the entry point of the coronary dissection, and we will see what happened. So we put the stents with 3033. So there's no flow again after the stents. So probably the hematoma is getting worse, or probably dissection is getting worse. Then we pull back the wire and wire back to that part. So sorry. And then we put another balloon, small balloon, to pre-dilate, and then to make the hematoma to resolve. However, there's a hematoma was not resolved to the RBDE, but RPL branch was improved in the flow. Then at that point, okay, we need to do the IVUS. We need to know what is happening. So this is an IVUS in a RPL. So the distal IVUS, distal RPL was normal, no atherosclerotic lesions, no dissection. So it's coming. There's a hematoma is starting there. So very obvious hematoma at 12 o'clock. Okay, 12 o'clock. It's getting more. Vessel size was quite big. See the stent is not really expanded well, and then the expansion still malopposition in some part. So, however, at the proximal part of the hematoma has been sealed off under the stents. So this is at the proximal end of the stent. After that, the lesion was no more significant lesion and no hematoma as well. So and then IVUS we ran one more IVUS in the RBDA as well. So you can see the hematoma in this part is very obvious. However, the wire is in the true lumen. So the vessel size was quite big, about 3.85. And then the distal part is 3.0, and then the proximal part is 3.85. So this is a state image of the IVUS. So then we did the post dilatation to the proximal part of the stents, and then we take a shot, show that still got residual dissection in the proximal part of the stent. However, this flow has established. So we decided to stop because we don't want to extend the stent. So if we extend the stent to the distal RC, worried that the RPL branch will be sealed off and then can cause a problem. So we decided and we will restudy again in 1 month time. So we did the restudy in 1 month. Still got the dissection. However, there's dissection in the RPL branch has been improved and then still got good flow. So we decided to extend the stents to the distal RCA, and this is a final result after the extension of the stents. So very good result. So the conclusion is that this is a probably spontaneous coronary artery dissections which make him recurrent unstable angina. The no flow phenomena because of the dissection segment has migrated to the RPE and RPL branch after the balloon pre-dilatations. So IVUS show long dissection with the intramural hematoma and RC and RPTA. And then we use the stent. There's multiple types of the PCI techniques for the patient with this kind of lesion. So we stent. Our aim is just to seal the entry point of the dissection, and we waited for 1 month to see the artery to heal. And then, however, the healing was improved in RPL, but the persistent dissection in RPD and RPL was there, so we need to extend the stent. So my discussion point is this is probably spontaneous coronary artery dissection, and then or maybe my wire make the dissection and which make the things complicated. So that kind of patient, whether we keep as a conservative management or we just implant the stent, because the flow was disturbed and no more flow in the distal. But if we leave it, I worry that it may cause the patient got the myocardial infarction and can cause a complication to the patient and will make the ejection fraction drop. So the dissection is extended distally. That is the most worrisome part of the patient with spontaneous coronary artery dissections. So then we use a technique to see the entry point of the dissection and hematoma. and then let it heal and make the flow better. And then we assess with the IVUS to see the lesion characteristic and extent of the dissection and stent opposition expansion. So I hope this is end of my presentation. Thank you very much. So open for the discussion.
Thank you, Dr. Winner. An excellent presentation. And no doubt when we see cases like this, our heart rate goes a little bit faster when this happens. Did you, going into the case and seeing that lesion, I mean, it looked like a simple atherosclerotic lesion that would take a simple stent and you're home, but you didn't initially suspect any spontaneous dissection, did you, initially?
I really didn't think about that one was dissection. Really think, oh, this is just an atherosclerotic rupture, probably. There's very simple lesion. I even told my staff, oh, we will finish very fast for this case. But actually, it would take for a few hours to settle the problem.
It's always the case. And did the patient maintain a relatively stable clinical picture, his ECG, pain during this?
Yeah, he developed a bit of chest pain during the procedure, but BP didn't drop. So probably because his left system was very, very normal.
Well done, well done. Any other questions from our panelists?
Dr. Wing, very good presentation. I'm Dr. Pu from China. I have two comments for this case. First, I think when the no flow phenomenon appeared in the first time, I think you should perform the IVUS to check what happened. So in that case, maybe you can prevent to put a shorter stent. So you can put a long stent to completely seal the exit point of the hematoma. And the second thing is, I don't quite understand why you just let the occlude the RPDA for 1 month. I think in that time, the patient will suffer some kind of myocardial infarction. So when you got the result of the IVUS, maybe you can put another stent to restore the flow of the RPDA. Maybe that's better. That's my point.
Very good comments there, Dr. Pu. Very good comments. And I mean, it's always difficult, you know, when your concern is that you're actually extending the hematoma and the dissection, and that's obviously the worry that you had, I think, clinically. But Dr. Pu made a very good point. Maybe the IVUS earlier on might have given you a bit more information there. And so long term, I mean, would you just manage the patient, you know, with statins and dual antiplatelet therapy as you would an ACS patient, a standard typical presentation?
Yes, we give the statins. We give the statin and DAPT for 3 months. So we basically at least 3 months for this patient because he had a history of 2 recurrent unstable angina. We assess the patient back. So we give the load. After that, we cut down the load. We just give the moderate dose of the statin. I think we give Lipitor 20 milligram only because because he doesn't have that much atherosclerotic lesion and cholesterol was normal also. And then DAPT for 3 months, I just give the aspirin alone and Lipitor only for the lifelong, this patient.
All right. Well, thank you again, Dr. Winner. Excellent presentation, an excellent case, and very educational. So our next case is Dr. Gopal Ghosh from the Rabindranath Diagnostic and Medical Care Centre in India, and presenting again on a very, very interesting and rather complex scenario here, looking at kissing Y stents to exclude a large right common carotid artery aneurysm in the case of Takayasu arteritis. So, Dr. Ghosh, lovely to have you here, and please start your presentation.
Yeah. So it was an 11-year-old girl from Bangladesh. She developed some pulsatile swelling over the right neck. And also she had a right upper limb claudication. And she was evaluated there by local physician. They found that there is a disparity in the pulse. There was absent right upper limb pulses. And on routine blood investigation showed that the ESR was elevated. So they did a arterial Doppler which showed that occluded right subclavian artery with aneurysmal dilatation of the right common carotid artery. So she was being referred to us for further management. So we straightway did a angiogram. This is the arch angiogram, LAO 45 and RAO 30 degree view. That is showing that, as you can see, that the right common carotid artery is diffusely dilated with a maximum diameter of 23 mm. Innominate artery is also, diameter is 10 mm. And you can see the right subclavian artery is occluded. just after the origin of the right vertebral artery. This is the selective innominate artery angiogram showing the diffuse dilatation of the right common carotid artery. This is the selective angiogram of the right subclavian artery, showing the right subclavian artery is occluded just after the origin of the vertebral artery, and the reformation you can see at the axillary artery level. So here we have decided to open the right subclavian artery first. So we have taken two axes, two femoral axes, and we put initially 2 6 French sheath. From the right femoral axis, we used one, we have upgraded the small sheath to an Ansel long 755 sheath, and through that, we have taken one GR catheter and a Terumo 0.035 guide wire, and successfully recanalized the right subclavian artery. Then we did a serial dilatation of the right subclavian artery, and initially with a plain balloon, followed by a drug-coated balloon called Impact Admiral Fort 120. Then we decided to stent the right common carotid. So we started from the internal carotid. We put a self-expanding Fluency 780 stent from the right internal carotid up to the mid part of the right common carotid artery, and we overlapped with another Fluency stent from the right common carotid to innominate artery, 10 into 60 mm stent. And for the right subclavian part, we put one balloon expanding stent. That is a first we put a live stream, that is a covered stent 637, and we stented the covered stent with another self-expanding Epic 740 stent. So this is the final angiogram. You can see the nicely reconstructed vessels with good flow in the vessels. This is the final angiogram. The aneurysmal dilatation of the right common carotid artery is nicely excluded, and good flow in the right subclavian artery. So my conclusions are kissing Y stent, although routinely used in aortoiliac and coronary bifurcation lesion, but when there is the stenosis or the aneurysm is very close to the right subclavian artery ostium, it is an attractive and effective option. And the type and size of the stent should be chosen carefully. Self-expanding stents are preferable. So my discussion points are maybe these few points may be discussed here. One is choice of treatment. Here, we should have chosen the stenting procedure. The other options may be surgical correction or the medical management, and whether to choose covered stent or bare metal stent, because this is an aneurysmal lesion, so we choose a covered stent. And the girl was only 11-year-old girl, and she had history of right upper limb claudication. She was not able to write her daily writings. So that's why we need to recanalize the subclavian artery in this case. So thank you. This case is open for discussion. Any comments from the moderators?
Thank you, Dr. Ghosh. An excellent presentation there.
Yeah.
And I guess, I mean, the fact that she's 11 years of age may, I think makes what you did, I think, a very good option, because surgery maybe in the more elderly population may have a role. And then post-procedure care and dual antiplatelet therapy, how do you do that in this patient? Is it a short period of time?
Yes, sir. Before doing the procedure, actually, we have started this patient on an immunosuppressant and steroid. We have given a 6-week steroid therapy. Then after did the procedure, and after the procedure, we continued dual antiplatelet therapy for 6 months.
Okay. And the choice of stent, I mean, in the aortoiliac, as you say, you know, the covered stents, but I don't have much experience in using it in this anatomy here. So what was going through your mind about selecting a covered stent versus a traditional stent in this case?
Sir, it was an aneurysmal lesion. The right subclavian, right common carotid artery was dilated. So we need to exclude the aneurysm. So in that case, anyway, we have to put a covered stent in the right common carotid. And if we are using right common carotid, we need better sealing. So that in that scenario also, in subclavian, the proximal part also, we had to put a covered stent for the better sealing to prevent the leakage. So that's why we put 2 covered stent in subclavian and also in the common carotid.
Yes. And I think the self-expanding is also a very good option here. Again,
yes,
I think, have you done many cases like this?
Yes, actually, I did my residency in Christian Medical College, Vellore. So it is an excellent center for Takayasu arteritis. So multiple lesions we have done in many patients in this kind of patient.
Very good, very good. Great experience, and I appreciate the case, very educational. Any other comments at all?
I'd like one question for you.
Yes.
We have to consider about indication of the procedure, because upper limb extremity occlusion usually asymptomatic. So main indication for this case may be for the aneurysm and coverage, but I don't know the rupture risk of the this kind of Takayasu disease. And if you treat the medication carefully with steroid or other immunomodulation drug, she is very young, and maybe the aneurysm can be shrunken on follow-up. So at that moment, conservative care can be another option, because you put various multiple stents, covered stents with a very complex Y stent, then make another problem, stent thrombosis. That is very dangerous for the cerebral supply. So we have to consider carefully to select this kind of procedure.
Yes, sir.
I want to ask, I think Dr. Gopal is excellent presentation because it's very rare in autoimmune in Takayasu, and interesting in the bifurcation technique in coronary stenting in endovascular procedure. In my opinion, the endovascular procedure for autoimmune disease, I think is recommended with the low CRP in inflammatory marker, because if it is done in a high CRP condition or high marker inflammatory, because increased incidence ER, instant restenosis or acute stent thrombosis is very high. It is important the marker inflammatory if you want to do endovascular procedure in autoimmune disease.
Yes, sir.
The second, does this patient have the symptomatic stroke, TIA, or neurologic deficit? I want to ask you, symptomatic or no, this patient?
Yeah, symptomatic, sir. Patient had right upper limb claudication.
Okay.
Yeah.
Okay, I agree about endovascular, but the important is the marker inflammatory. If it's still high, you must to decrease before do the procedure, because it is important. Because in autoimmune is very high instant restenosis or acute stent thrombosis if still high marker inflammatory. And if the patient no have symptom or neurologic procedure, I think the best is only optimal medical treatment, because it's many trial, many case, corticosteroid moderator is very good for long term for the patient if no have symptom. This is key point. Okay, thank you.
Yeah, thank you, sir.
Dr. Pasciolly, very good comments there. I think very important to obviously assess cases, each case individually. Dr. Gosh, can I just ask, just for my own information, would you normally then screen this patient for other arteries and other vascular beds?
Yeah, actually, sir, if any patient we clinically suspect Takayasu arteritis, we routinely do all the aortic angiogram aortic root angiogram, pulmonary angiogram, and coronary angiogram.
Oh, yes. Okay. So
Yeah,
you do
to
do all
classify.
that.
Yeah, to classify the patient.
Okay. Okay. Thank you very much, Dr. Ghosh.
Yeah, thank you. Thank you, sir. Yeah.
So I want to move on next now. We've got our final presenter, and we've got Dr. Shahan Singer from the BSMMU, Medical University in Bangladesh, to talk about the role of echocardiography. And the topic is where life is on the rope. So Dr. Singer, welcome, and thank you for joining us and giving us this what will be, I think, a very interesting presentation.
Okay, Honorable Chairperson and respected moderator, very good afternoon to all. First of all, I pay my deep respect and feelings to the person who have died in this corona crisis. You know, we are passing a very tough time in this era. And so my topic is role of echocardiography where life is on the rope. My patient, a 65 years old gentleman who was diabetic, hypertensive, having autosomal dominant polycystic kidney disease. He presented to our emergency with history of fever and cough for 10 days, progressive breathlessness and central chest pain for the last one day. And initially, he had been woke up at home by the guidance of me and diagnosed as a case of COVID-19 on the basis of RT-PCR positive and HSCT show bilateral ground glass opacity around 40 to 50%, but his SpO2 was quite normal in room air. Apart from this, he had supportive investigation like lymphopenia, high CRP, ferritin, and D-dimer. This is his CT scan showing the bilateral ground glass opacity. And in our hospital emergency, when he attended, he was fully conscious, but he was unable to complete the sentence, and he was cyanoused. His hemodynamics was not good, and he had a high respiratory rate, and SpO2 was around 60 to 62% in room air. And all on a sudden, he undergo a cardiac arrest, and fortunately reverted back by giving effective CPI and shock. After that, he was put on high flow oxygen. IV channel was opened, inotrap given, rapidly necessary sample was sent for investigation. And in the mean, a 12 RECIST was taken, which revealed the S1Q3T3 and complete RVV. And so, following this, we kept in mind, we do and focused echo by taking our protection. And in this echo, this is the pastoral long axis view showing the RV was easily dilated and it will be small. And in the still picture showing the measurement of RV reveals the RV is dilated 37 millimeter, while LV is only 21 millimeter. And this is the pastoral short axis view at the level of papillary muscle showing the D-shaped LV. And there's a minimal pericardial effusion. RV is usually dilated. And there is a very hypokinetic movement in this part of RV. And LV function reveals concentric LVAs with good LV systolic function. And this is the echo in the left pastoral short axis view at the level of great vessel showing there is a large sidal thrombus in the main pulmonary artery, which occlude the pulmonary vessel. This is the zoom view. And this is the measurement of the thrombus reveals 33 into 20 millimeter. And unfortunately, I have lost some picture. So this is the still picture I having showing when the color was given. There is a tiny amount of color of fast dilation, and tricuspid regurgitation was seen, and there's a moderate pulmonary hypertension, and there's TAPC was only 12 millimeter. So moderate RV systolic dysfunction was noted. So our echo impression was this large sidal thrombus in the main pulmonary artery, dilated RV septal flattening, mild to moderate TR with moderate pulmonary hypertension, mild to moderate RV systolic dysfunction, concentric LVs with good LV systolic function with minimal pericardial effusion. So our final diagnosis, this is a critical case of COVID-19, giving rise to acute massive pulmonary embolism with cardiac arrest survivor. In addition, he has history of hypertension, DM, and autosomal dominant polycystic kidney disease and AKI. And in the main other investigation was troponin was markedly raised, and D-dimer was also markedly raised with raised anti-proBNP, and his AVG revealed type 1 respiratory failure. In the main duplex study was done, but no evidence of lower limb thrombus. So we know that according to guideline, when the RV overload happen, there's consequence. It affects all the left system, and if the patient is untreated, ultimately giving rise to obstructive shock and death. And this is the proposed algorithm for the treatment of pulmonary embolism in a COVID-19 patient. If there is no contraindication for anticoagulation, they have to give the anticoagulation heparin drip, followed by if the patient has hypotension or cardiac arrest. And if the patient is candidate for TPA, then we have to give. And accordingly, patient as his saturation was not maintained, so he was on mechanical ventilation. And along with heparin tube, we give the IV altiplase thrombolysis was done. And he was so fortunate that he under a rapid recovery, and we extubated the patient 20 hours later. And then we stepped down into the ward and put on low molecular heparin. And we know that there is several mechanism for developing a pulmonary embolism in a COVID patient. There's when the disease becomes severe, then huge cytokine storm giving rise to different sorts of inflammatory cytokine, and hypoxia leads to increased blood viscosity, hemostatic abnormality. So there's lots of chance to develop the pulmonary embolism in the different site. And the different literature reveals, despite the taking the PUPA anticoagulant, the patient developed a significant patient developed pulmonary embolism. So after that, before discharge, we done an echo, which revealed the complete dissolution of the thrombus in the pulmonary artery, and the meconal sign also improved, and the RV function reveals quite normal. And before that, we done a CT angiogram to pulmonary angiogram to see the thrombus in the different site, but fortunately there was no thrombus was seen, and he was discharged on the 8th day by giving the anticoagulant for the consecutive next 3 months. So my take-home message from this presentation is that we know that COVID-19 is a highly contagious and potent condition, and acute mesopulmonary embolism is a life-threatening condition which can be seen in a significant patient to patient. So any patient presenting with respiratory distress apart from the hypoxia have to keep in mind, and we have to take the protective measure by doing and echo if it is available, because we know that echo is a very cheap, widely available, and easy to handle, and it has a tremendous role for early diagnosis, hemodynamic assessment, and exclusion of differentials, and also we can see the prognosis. And we have to assess clinically, and early evaluation of echo is very important, because we know that effective treatment can save the patient life. You know, every life is very 100% to each individual. So thank you very much. Despite the taking the vaccine, we have to keep the masks and social distancing still yet. So thank you very much for your patient sharing.
Well, everyone is having a depressing day for the last year because of Corona, and it was a really good, excellent case, and you diagnosed it very well and treated it very well. Are there any comments or questions from the panelists?
I think it's a very good case because I once worked in ICU for COVID-19 patient for 2 months. So actually we saw a lot of patients with COVID-19. They had very high D-dimer and they have low oxygen saturations. So in that case, sometimes it is confused for the doctors whether the low oxygen comes from the COVID-19 itself or come from the PE. I think a lot of patients may have PE, as you have mentioned. So I think in this case, because these patients, some patients are limited to CT, especially enhanced CT. So echo is a very, very useful tool to quickly examine these patients. So very good case. Thank you.
Exactly. Thank you for your nice comment.
Thank you very much. Thank you, Dr. Singer. That was excellent presentation. And we often see that the COVID often translates into a pneumonitis. Have you seen many of these cases with pulmonary embolism? I mean, such massive pulmonary embolism.
In our university, there is a large COVID ward. So for the last couple of months, we have seen 5 cases by doing 5 cases by doing an echo. And in CT pulmonary angiogram, we have done 16 cases. We have saved the life 16 patients. So it's a quite high. So it's a very highly pathognomonic state. So when despite the proper treatment, when a patient down, so you have to kept in mind the bedside echo if reveals RARB dilatation with pulmonary hypertension, we have to keep in mind that something is going and we have to start the PE.
I think you're right. I think it's actually getting in and doing the investigation soon. Obviously, there's a bit of a concern of staff going in to scan and assume that it's all just pneumonia related. But I think you've shown that your work is with imaging. You're a lifesaver. You've managed to go in there, identify the problem, and this patient to be extubated in a couple of days is phenomenal. Phenomenal result.
Exactly. Now patient is doing well, and he's very happy that he is very much glad that you have saved his life, and he is very much happy that he has, despite the very bad or extreme health, now he become well.
Well done. Well done. Any final comments? No. Look, I think it's been an exceptional hour of cases focusing on all aspects of intervention, structural, imaging, and I really want to thank all the speakers. You've done a phenomenal job presenting your cases. Thank you to the panelists, and a big thank you also to my co-moderator, Dr. Lee. It's great to be with you all the way from Melbourne, Australia. And again, I look forward to joining you again next year. Thank you, everybody, and bye-bye for now.
Okay, thank you.